So Jen, you know the rules. You've seen the past couple, I think. This is the PICU setup. We have Dylan again. He's an unfortunate guy. Every week something bad happens to him. Let's call him 5 years old. Let's call him 50 pounds, 22 kilograms. And I am at your disposal as the resident at the bedside. I can do things that you want me to do. I can answer some of your questions historically. You'll have access to see the patient, obviously. You'll be able to see the monitor. You'll be able to see pop ups if we have pop ups this week in terms of labs and studies and so on. And I'll put on the headset and we'll go from there.
Looks like he's hypertensive and bradycardic. Do we have any history as far as what's going on?
So, Dylan, like I said, I'm the resident from upstairs and I called the rapid and then accompanied him down here. So, he is 5 and he was in the hospital on the red team because he was vomiting. He's been throwing up a lot and he was dehydrated. So he had hypernatremic dehydration. His sodium was like 151.
Is he, I mean, his stats are 94, but he's not responding. So then we need to think about intubating him. Can we at least have a mask on him?
Sure.
And what is our access?
I have this PIV in his right AC, and the nurse on the floor told me it works.
I mean, as much as I'd like to be able to give him medication, I think the best that you need to do is get that breathing tube in him to secure him. I would be inclined to just put the tube in. I know you have med there, but I don't know.
Okay, I have the laryngoscope in. I can see cords, tubes in. This is a 5.0, so how deep should I go?
So you should be no more than 15 centimeters. So we need to start compressions for him. He has no blood pressure either.
No.
And we need to drop epinephrine. The dose should be 0.1 milliliters per kilogram. So he's 22. So we could do two mLs of the epinephrine in his IV.
Okay, I'm plugging the epi in. Epi's in. I'm flushing it.
And continue compression. It's very possible that he has an acidosis. I'm not sure necessarily the etiology behind it. If this was going on at home, do we need to consider DKA for him? That will come back on the BMP. There are other causes of an acidosis he could have.
I'm checking on my phone right now and see if that gas is back on Haiku. It says 716 78 CO2. It says it's bicarb.
Yes, it's been 3 minutes.
Okay, plugging in another epi.
And we should be continuing compressions as well.
Flushing that.
I mean, what sounds like a lactic acidosis. The question is why. I know he's gotten some fluid, so we can certainly give him another bolus.
Okay, I have a push pull over here.
So let's do
syringe.
20 per kilo for him. So do a 400 cc bolus.
Yep, I'm pushing that in now.
He came into the PICU hypertensive and bradycardic.
Yeah.
So that to me suggests that there might be an intracranial pathology.
Want me to check his pupils?
Yeah.
Okay, I can check his pupils. We can display that. We'll get a close up from the camera for you.
Do they respond to light at all?
That big one is not responding to light. I'm using the laryngoscope light. It is not responding. It's like big and dilated.
Okay. Yeah, I see on the left side. Okay.
Yeah. The other one is kind of tiny, but the big one, no light reflex.
Okay. So we need to be able to relieve the intracranial pressure that he's having, but we only have the one PIV, so we're going to need more central access to be able to deliver medication.
It just so happens that I have some hypertonic saline right here. How much would you like me to give?
Let's do 3 per kilo. It's 3%.
3% saline, 3 cc's per kilo, you said?
Yeah.
Okay, that's in and flushed.
He's 5, so you can start him at 20, but we need to be able to maintain his end titles.
Okay, I will get on the phone and call Dr. Campbell right away. So why don't we pause there and we'll start to do it. Okay. So Jen, take me through it. Take me through the beginning of this scenario. Tell me about who the patient was, what was going on, what you thought was going on, and what your differential looked like.
Yeah, so it's a 5-year-old that was here with emesis and hypernatremia, bowel obstruction. As we got the labs back, he had the elevated lactate, that I guess didn't necessarily discern between the two, but the ongoing duration of the emesis and the fact that it was temporally related to days and nights had me thinking more of the intracranial pressures, which is I think more when that management changed. I mean, his gas suggested an acidosis, lactic acidosis. Starting
But right
to
off the bat, from your vital signs, you were going down the right path. You said he's hypertensive, he's bradycardic. You said it really early. And you could have hypertension and bradycardia with cerebral edema and DKA as well. To the point where you recognize, you said he's hypertensive, he's bradycardic, and you picked up very quickly that I was changing the monitor, and you're like, is he breathing? Seems like he's breathing slow. And then I made him breathe even slower, and then I made him stop breathing. And you picked up on that right away. He's got no heart rate, he's got no blood pressure, everything went to zero. And you also saw that. You're like, everything's zero. We got to start compressions right away. You were right on top of that.
Intubation without sedation and stuff.
So even in the semi-obtunded herniating patient, I usually will give them something because I've seen the active laryngoscopy make something herniate. It's enough of a noxious stimuli, even in the patient that you're like, well, he doesn't seem to mind sternal rub. He probably won't mind this. Putting that blade in the back of the throat and activating vagal nerves and feedback tends to push them over the edge. So
Okay.
let's talk about that for a minute. If we had said we're going to do some kind of modified rapid sequence intubation, is there any particular drugs that are kind of classic for the guy who might be herniating? What drugs do we want? What drugs do we want to stay away from?
Lidocaine we would probably add to.
Yeah, or, pentabarb, I would have given somewhere between 3 and 5 per kilo of pentabarb. Why are we doing that? Why a barbiturate? And it may not prevent herniation. It may not improve your ICP when you have an obstruction like this big tumor that we have here obstructing CSF flow. But at least the cells that are there in the brain are so asleep and so kind of hibernating that if there is some period of lack of oxygen, lack of metabolites, they don't suffer as much because their metabolic oxygen consumption is lower. So barbiturate, lidocaine, neuromuscular block. And then what else could you have used that's very common? And I would have said, yeah, that's a good drug.
Could you have thought of etomidate?
Could have used etomidate. What else that we kind of commonly use every day, like water, would have been okay as well.
Propofol.
Propofol probably would have been okay. Also is a general anesthetic, decreases cerebral metabolic oxygen consumption. Giving a large bolus and decreasing the blood pressure too rapidly could decrease the cerebral perfusion pressure. So that's a danger. Once he arrested Jen, you were right on top of it with CPR. You were right on top of it with epi, the right dose, 0.1 cc's per kilo of the 1 to 1,000 or the 1 to 10,000?
1 to 10,000.
The 1 to 10,000, so the IV or IO version of epi. And then we're circulating that with good chest compressions, and we're redosing every 3 to 5 minutes, and we're doing pulse checks every 2 minutes. So, but what kind of led you down that road of, all right, I want to focus on the head?
The fact that the other interventions for like an unstable bradycardia were not, epi itself wasn't working. We had the vital signs that were suggesting that there was and the triad that it was increased pressure.
Okay, so once we have him on the ventilator, and notice our fancy new, he's even got a ET tube holder that John and his team created, so he looks pretty real.
My primary focus, like when I was trying to pick the vent settings, was keeping the end tidal around 35 as part of the ICP management. And then, with that, just the tidal volume of 6 per kilo, which is what we typically at least default to. And he didn't have any kind of lung pathology regular Pete for the same reason.
Yep.
And then the rate, just that he's like around the kindergarten age, I felt like 20 was kind of right between where you would see a normal respiratory rate.
Especially in this patient who has that CT with a big posterior fossa medulloblastoma. What could raising the head of the bed, possibly do for you to be helpful?
In theory, it should be able to help lower or at least not raise, but I guess however you want to word it, lower the ICP by allowing drainage,
Drainage of what?
the fluid through the ventricles,
Yep.
if it's obstructive.
Yeah, absolutely right. So if you have CSF that's obstructed by this big tumor, making gravity your friend, making maybe a few drops, a few cc's of CSF drip past that tumor down into the spinal cord and out, might be helpful enough to get you back on the ICP curve. You've seen me draw this a lot, where it's flat, it's flat, it's flat, and then a very small change in volume gets a very big change in ICP. So does anybody else want to pinch hit? Jen has identified that's important, and it might lower ICP. What's the mechanism? Deepika, are you?
Yeah, basically vasoconstriction and decreased end titles would cause cerebral ischemia by causing vasoconstriction. I mean, I think when there's in danger of herniating, you hyperventilate, and then after that, to maintain adequate CPP, you would target end titles.
Yep. So we have two vascular systems in the body that kind of are an opposite or in opposition to the response of CO2 and pH. And if we hyperventilate,
I mean, yeah, so I suggested the hypertonic saline, which I think is usually you can do like boluses of 3 to 5 mLs per kilo. And kind of regardless of what the sodium is, we don't really necessarily pay as much attention to that, just more even to vital signs and kind of his clinical exam.
Yep. What about the idea of giving it through a PIV though, Dana? Isn't that dangerous? The floor gets very, very focused on that when that has to happen.
I mean, you can, if you could had a midline, like you could always do a midline as well. I've done that before for like in ICP when we didn't have
a PIV.
That's, yeah, I guess if you're desperate times for desperate measures, you could start it through a PIV while you're gaining additional access.
Dr. Penfield used to like to say life or limb. So yes, he could infiltrate. He could lose his hand with a bad infiltrate of hypertonic. What is it supposed to do, Nisha? What is hypertonic saline or mannitol or both? Maybe they don't act the same way. What do they do, and why are we doing that?
They're both hyperosmolar, so they will draw water out from the swollen brain cells out to prevent the high ICP. So we're attacking the other box in the Cushing's triad.
Yep. So we talked about the hypertonic saline dose. How about mannitol? How much am I supposed to give?
You give 1 gram per kilo.
Yep.
Mannitol.
So you can give it as small as a 1/4 gram, 1/2 gram, 3/4 gram, or a full gram per kilogram of mannitol. And then, Nisha, you mentioned this.
We're trying to protect the kidneys from osmolar load and injury.
Yep.
So for mannitol, we try to keep the serum osm less than 320 because some adult studies showed that anything over 320, there was chance for ATN and ischemic injury to the kidneys from the osmolar load.
Yep.
And hyperosmolar, I think we just target 360, although I don't think there are enough studies to prove that 360 is the number.
So there are some studies for hypertonic saline that said that you could go above even 360. Most people use 360 though as their number. You definitely can go above the 320 of mannitol, but as Nisha said, you're worried about absolute desiccation of the tubules of the kidney, where they just kind of shrivel up and die because you've given them such an osmolar load to try to filter. So those are kind of our guidelines for hypertonic and for mannitol. Is there an advantage of one over the other theoretically, Kostov?
I guess the one thing is mannitol being a larger molecule causes has the diuretic effect worse than 3% hypertonic. So you have the risk of diuresing that person more And also being a larger molecule, the nephrotoxicity of mannitol is more than hypertonic saline.
So
I guess both of
some people do worry about mannitol being more of a diuretic agent and lowering your cerebral perfusion pressure further in a person that's depending on it.
Exhibiting all of them with Cushing's triad. And then I guess the important takeaways are the sedation with intubation to prevent arrest, the management using hypertonics or mannitol and why, what to consider for initial stabilization, and then more of the long term with steroids and further intervention.
Okay, very good. Folks, any last questions? Next week, I think we're going to take a week off of this because I'm on service and I won't have my headset and laptop with me at work. It'll be here. We'll probably take a week off of virtual mock code and then try to resume the week after that.